Healthdirect has the potential to be a game changer at a community-based level in terms of demand reduction, in terms of consumer-based knowledge which change direction of health services, and eventually one hopes in secure messaging. Wouldn't it be nice if you didn't have to use your fax machine and teach young graduates what a fax machine actually is? Healthdirect potentially is a way to go yet, but has the directory which will allow that secure messaging to occur. But anyway, to talk about some of the innovations with Healthdirect, our first speaker is Mary Byrne, who's Service Director of Healthdirect Australia. Please welcome Mary.
Thank you very much. Actually, the directory was the one thing I was not going to mention, but I'm glad that it was brought up. It is one of the things that we do have. For those of you, and I know that a lot of you are using your mobile phones to put in questions and vote on topics here, can I ask you to do one more thing? If you don't already have it, go to your relevant app store, have a look for the Healthdirect app and load it on your phone. I'm perfectly happy for you to do that while I'm talking. It encompasses a number of the services that I'm going to be talking about today. What is Healthdirect Australia? Healthdirect Australia designs and delivers innovative services for governments to provide every Australian with 24/7 access to trusted information and advice that they need to manage their own health and health-related issues. It's an organisation that has been set up by the Commonwealth Government and most of the state governments, including New South Wales. So we are a service for you. You provide the money for us to help provide services across healthcare. And so you need to be using the services that we provide. We design and deliver innovative services. We are in the space of telehealth, e-health, helplines, digital services. We provide everyone with 24/7 access to trusted information and advice. One of the components of Healthdirect Australia is a very strong clinical governance team. What we do is clinically safe, is clinically checked, and therefore is trusted advice. It's also advice that's relevant to Australia. It's based in the Australian healthcare system. So when you tell your patients about these services, you can know that you are providing them with something that will be relevant to where they are and that will fit in with the rest of the Australian healthcare system. The most important thing, and the reason I want to talk to you, is that we provide information and advice and services to help Australians manage their own health and health-related issues. I think the goal is to enable people to know the next time they have a health issue, when you see them, the next time they have a health issue, there are tools they can use to start to manage their own health. That's not to say that there won't be advice for them to turn up to your emergency department to go and see their GP, go to community practices, but they can understand more about their health issue, and often there's advice about how they can manage it at home. So that's the important thing that we provide, is a complement to acute and face-to-face services where people are able to find the information they need and know what to do about their health issues. We cover quite a few services. What I've shown up there is an array of things, including the Healthdirect helpline, after hours GP helpline. We also have the pregnancy, birth and baby service, which has been mentioned already today. From the Commonwealth perspective, we'll look at My Aged Care and the Carer Gateway. It's playing up, okay. And as Norman mentioned, the National Health Services Directory. More specifically in New South Wales, as well as some of those main services that are available in New South Wales, we help procure and manage the Quitline in partnership with the Cancer Institute. We have the New South Wales Palliative Care After Hours helpline that was recently launched by the Minister, and the Get Healthy service. So there's a number of services specifically in New South Wales that you can also tell your patients about. What do we do? A lot of things. In the last year, there were 14 million visits to our websites, 66 million transactions on the National Health Services Directory. Every 15 seconds, one of the operators on one of the health lines had a contact, and we had over 2 million contacts handled by the helplines in the last year. 55,000 visits to the Healthdirect app, so I hope you're all contributing to a few more of those. and over 500,000 visits to the online symptom checker, which is both online on the website and in the app. I'm just going to talk about the main services under the Healthdirect component of our services. So we have a website with safe, practical and trusted information. There's a whole section, as you can see across the top, on medicines. If your patients want somewhere where they can go to look up whatever medicine they are on, they will get information, they'll get consumer medicine information, they'll understand what it's like, how to take it, and general advice on managing medications. There's a whole section on that on our website. As I said, there's an online symptom checker, so people can check their symptoms themselves. It gives them advice about the level of care they need and the urgency of that care, but more importantly, how they can manage those symptoms. Even simple management of the symptoms while they get themselves to their GP or to an emergency department. And then there's a lot of general health information on conditions, on how to manage different aspects of your health, and that content is growing every quarter. You will find on the website feedback forms, and again, we welcome input on the sorts of content that people want. Our goal is to be there preparing consumer-facing information, and that's where our editorial team are now quite good. And so if you want to know how to work with or how to have consumer-facing information, please get on to us and look at what we have on our website. As I said, we have the Symptom Checker and the Healthdirect app, and both of those are available for people to use. And then we have the helplines. So the Healthdirect helpline and after hours GP helpline, the nurses are available 24 hours a day, 7 days a week, so people ring that number and they are triaged by a nurse. In the after hours period, if they would have been recommended to see a GP, they can then speak to a GP on the helpline. And we find in about 70% of cases, the GPs are able to give enough advice for the person to manage their symptoms until morning, until business hours when they can see their own GP, rather than needing to go out and see someone in the after hours period. The nurses give advice across a whole array of outcomes, everything from maybe getting an ambulance, but through to going to see a pharmacist and caring for themselves at home. So again, there's good advice available for people when they have a concern about their health issues. As I mentioned, we also have the New South Wales After Hours Palliative Care Helpline. This is a line that is there to help people manage when they are in the palliative care of their phase of their life, manage their concerns. It's not necessarily to stop people from going to hospital, it's to give people options, to understand how to manage the concerning symptoms that develop in people with terminal illnesses. So the call is answered by a set of nurses who are on the Healthdirect helpline who have training in palliative care, and they attempt to work with the caller in the caller's current management plan. So whatever plan is in place with their palliative care provider, that's what the nurse works with and helps them put that in place or gives them advice if they don't have anything that can manage their symptoms. Information is then provided back to the palliative care provider associated with that person, and if necessary we then have a subset of nurses who are specialist palliative care nurses who manage the callers with more complex issues. So that's a very important service available now for people all across the state who are in the palliative phase of life. Nope. Has that moved up there? No? Yes, there we go. Nope. There. So finally, what's the message that I'd like you to take away? What we are providing you with is tools for your patients to increase their capacity to manage their own health. It supports users to manage their health where that's appropriate, provides them with advice about the right level of care to seek when they do need face-to-face care, and it helps users understand their own health issues. One of the objectives for Healthdirect Australia that was set when we were first set up is to increase the health literacy of Australia. That's an incredibly broad objective, incredibly challenging, but each time you encourage your patients, the people that you interact with, to go and look up advice about their health issue next time, to work their way through a symptom checker and answer questions themselves about their health issue, they are learning a little bit more and understanding a bit more about their health. So my message is, please use our services. We are here to complement and as an adjunct to your services, but we're here to help your patients manage their own health. Thank you.
Thanks, Mary. Just given we're short on time, would you mind sitting here so we're ready for the questions after, if that's all right? Thank you very much indeed. Alan Loudfoot has 30 years experience at a senior level in ambulance services, and at the moment he's Executive Director of Clinical Services of Ambulance New South Wales and a major partner of Healthdirect. Please welcome Alan Loudfoot.
Good afternoon, everybody. Yes, I'm going to take you through a 10-minute whirlwind tour of really New South Wales Ambulance and its interactions with Healthdirect, primarily in the role of secondary triage. I'd like to put it into some sort of context, and here we are. You'll see this is the life of ambulance. We're now probably 1.2 million responses per year, or calls, and you'll see, keeping in the flavour that Mary talked about, once every 27 seconds the system kicks in. That runs all day, every day, and 2,300 emergencies a day. Extremely busy service. Again, in the context, so we've got 27 seconds between each job. We've got 800,000 square kilometres, 250 plus ambulance stations or air assets throughout the service, and all that is, like I say, figuring every 27 seconds. So why did we partner with Healthdirect? That was primarily around part of our strategic planning, and as you'll see within there, it's got the right response to the right patient. We all know in health that's a real challenge for us to get the right people to the right facilities first time, and that saves us a great deal of duplication. And secondly, increase the use of, says there, telephone triage, and that's our partners Healthdirect. How do we do this? Well, this is a real challenge for us. We have to determine within those 1.2 million calls, within probably a minute or 90 seconds, which calls are going to go high acuity and respond lights and sirens, traditional ambulance, which ones will be in a slightly slower queue, and that's our interfacility transports and from GP surgeries, and thirdly, which ones will go to Healthdirect. We use a relatively blunt tool and a very effective tool, as I'll explain later, and those cases go there, and we make sure that we have the right exclusion criteria. Exclusion criteria, you'll see there's two main criteria there. Third-party callers, that's about managing risk. Can we afford to send it when we're not really sure what's actually been happening on that? Schools, there's lots of evidence that we should be responding traditional ambulances to schools. On the other side of it, when we have advice from our professional colleagues, we obviously always send the traditional resources to those. These are some of the examples of the types of calls that we refer. But I'm sure the clinicians amongst us all here will say, it's never quite as easy as it seems. Yeah? The headache is a headache, the headache is a subarach, the headache can be almost anything. But you'll see in a moment that we do have areas that actually manage the risk associated with that. You'll see we do have 84 out of 1,000 determinants that are eligible for secondary triage. Call volumes. So this is really what happens. This is what we're really dealing with. So you'll see that over the years we've had a significant increase. We're projecting over 40,000 calls this year to go to Healthdirect. And remember, Those calls are going within a minute or 90 seconds of assessment into that process. So it's a significant amount of work that goes to our secondary triage providers. Returned calls. Clearly, all the calls we send don't all result in other services or referral to other areas. So we do have very robust governance processes that manage that. Emergent calls. You'll see there an average of 1 emergent call per 3 months. We all do the maths and we work it out. It's probably 1 call that comes back as a red call every 10,000. That says to me that's extremely safe in terms of the calls we're actually sending there. We do have a number of calls that come back, and they're usually warm transfers, and that's where the caller and Healthdirect and ambulance are all in a conference call, and we transfer that across so there's no risk. And you'll see that we do random selection of calls, 50 calls, and we check all those calls to make sure that we think we did the right thing and our colleagues at Healthdirect do the right thing. Productivity savings. Well, the first thing I should say is productivity is marvellous, but the real thing about this is actually giving the patients that they need. They don't need to go to an ED, they don't need a traditional ambulance. They sometimes need health advice, self-care, go and see a GP, various other things. So that's a primary thing. But from an ambulance perspective, we do get productivity savings. And as it says there, that's the equivalent of a large Sydney ambulance station, which is significant. That would be a multi-module station like Sydney Ambulance Centre. So it's a really good saving. Systems improvement. We work very, very closely with Healthdirect every month, and we're looking at what we can put in safely. Low acuity falls is another area that we're looking at, but we're trying to manage the risk associated with that. And we're also looking at mobility status, so when calls come back to us, we can potentially refer them on to other service providers like non-emergency patient transport, community transport. And another area we look at is have an exclusion criteria of over 75s, where we have a high return rate from Healthdirect. So we're just trying to make sure that we do have the gains within it. Governance. This is the dry area, but I am the Exec Director Clinical Governance. We do have our Clinical Governance Committee that has an independent chair, and the Service Improvement Delivery Committee, Healthdirect and Ambulance and Health, report into that Governance Committee. And we also have a Response Grid Committee that provides that governance. In summary, what I would say is this is a very exciting relationship that we have with Healthdirect. We're mature in our relationship. We can see the real benefits for the patients, and we can see productivity benefits throughout the whole health system. So thank you very much indeed for listening.
Alan, have a seat beside Mary. We'll have a few questions on Slido, so take a seat, Alan, beside on the couch. Mary, can you cope with more calls? I mean, you seem to be asking for more business earlier. Do you really want more business?
We have capacity for some more calls. We're also looking at the messaging that we give so that some of the calls that we receive, people can find the information online. I will always say we need to have a phone line in the system, that people need to be able to have the opportunity to ring, because for a number of reasons that may not be able to work with the services online. But that's why I spoke about it as a complete service. As a complete service, yes, we have a lot of capacity, and we would seek to encourage people to move through the different components of that service.
So one of the worries is that people use the symptom checker for self-diagnosis. So to what extent are you relying on self-diagnosis here? Not necessarily just in the emergency calls, but generally.
The first thing I would say is the symptom checker does not provide people with a diagnosis. So as much as they may attempt to use it for self-diagnosis,
It's a triage tool.
It's a triage system. So I guess the second thing I'd say about the symptom checker, as a clinician, it's very hard for clinicians to go in and test it, because a clinician goes in and thinks, I've got a migraine, let me see how the symptom check is going to work. A person with no clinical knowledge thinks, I've got a bad headache, is it really bad that I have to do something about it, or is it something that a couple of aspirin will help? That's the way you should approach the symptom checker, not the how does it treat migraine. And what it does is say, this is what you can do to help yourself, and this is the level of care you may need to seek. So the symptom checker will never tell people a diagnosis. However, the other side of your question, the concern about people self-triaging, yes, there has to be an element of caution in the symptom checker that is not there in the online, in the telephone service, where the clinician can clarify questions. So again, if you think it seems a bit cautious, yes it is, because we're trusting the general public to manage their symptoms and triage their symptoms themselves.
Alan, people often think, but not necessarily people in this room, that the problem with ED demand and when you lose the 4-hour rule is after hours. But the evidence suggests that it's actually people with chronic complex illness coming in with acute illness, and often people who might not want to be treated themselves coming from residential aged care and home. What are you doing about the problem, this issue, where there are unnecessary transports for care that people don't necessarily want or need, and where there might be an advanced care directive in place which you don't know about?
That's Alan's question.
Would you like me to answer, Mary?
Alan is taking them, so
certainly.
Welcoming emergency departments.
Yeah, I think the big challenge for us is really to get the message out to aged care, to get the message out to primary health care as well, is a matter of other alternatives or the first steps that we can take rather than the first option being ED.
So let's imagine a time, because it's already there on My Health Record, where we're fully engaged in My Health Record, people are being enrolled, people in aged care have got that, and you can actually load an advanced care directive into My Health Record. How does that change the call? You're getting called by the nursing home, and first question you're going to have in the 000 is there an advanced care directive? Are we already asking that?
We're already asking that, but we're actually driving an initiative where the advanced care directives, palliative care plans, are logged into the ambulance CAD system. So what occurs with that is, when you actually put the call into ambulance, they still get the ambulance, but the ambulance clinicians are informed there's a palliative care plan in place.
So you manage it in situ rather than transferring?
Correct.
Mary, final question. Sorry, go on.
Can I just add something to that? Particularly in terms of aged care facilities, we have a system within the Healthdirect helpline where staff can ring from residential aged care facilities and they'll be fast-tracked to the GPs. So when they are a healthcare professional about a patient, and it's less relevant in acute facilities, there's obviously escalation processes in acute facilities, but particularly to support residential aged care facilities, they can fast-track.
So what magic does Healthdirect, what magic wand do you wave to find a GP who will visit a residential aged care centre?
No, this is about talking to the GP on the helpline.
Oh, I see, okay.
So
you're getting me excited there. You could get a GP to visit, right? Okay.
Quite a bit of it can be resolved by talking to the GP on the helpline in terms of what you can and may or may not be able to do to manage the person in the aged care facility.
And final question, Mary, are GPs threatened by Healthdirect? I mean, you could actually, replace them in some instances.
Well, first of all, the GP helpline is GPs, so obviously they're not replaced there. I come back to my message. We complement other parts of the system. The strong message in the online symptom checker, the strong message from the nurses is where you need face-to-face care, we focus on go to your own GP. We try to promote this message of having a GP who is the person who coordinates your care. And we can support that. Yes, we've spoken at times with the RACGP. There are GPs that don't like us, there are GPs that do like us. Obviously, it's a mixed bag with that. But again, I'll just say we are there to complement other services and provide the support when other services are not there. And particularly in that after hours period. 70% of the calls to Healthdirect helpline are in the after hours period.
Could you please thank our two speakers in this interesting session? And I'll ask Jeremy McAnulty to come back to close this session.
Thanks very much, Norman, and thanks to all our speakers and panellists today. I think it was a very interesting session. I think the meaty public health challenges, obesity, HIV, managing the increasing need for emergency acute services, and innovative responses. But some of the themes were working across government, and often not just a health problem. It's the power of other agencies, the power and importance of dealing with the patients and community at risk on a one-on-one or at a population level, as well as retooling the services. An innovative way based on evidence is so important. Thank you very much for attendance, and don't forget that you can use, I think, the graffiti wall and also the hashtag New South Wales Health Innovation to share your thoughts and ideas, and let's continue to collaborate and innovate. Thank you.
Thanks very much, Jeremy.